Hello, hello. Can you hear me?
Yes, I can.
Oh, good, good. It's me. Just realized I'm out of charge. I had to move.
Hi. ഇവിടെ വന്നാൽ മതി വീഡിയോയുടെ
Hello, Dr. Nirja.
Hi.
Hello, Dr. Gupta.
Hello, doctor. How are you?
I'm fine, thank you. What about you, Vijaykumar? Nice to see you.
Hello, Dr. Shankar. How are you?
I'm fine, Dr. Nirja. What about you?
Very well. Thank you. So nice to see you after many days.
We are living in very strange times, Dr. Nirja.
True. So
Yeah,
true.
yeah.
But
I
it's
think
amazing actually seeing each other more often with these webinars.
True.
Hi, Dr. Vijaykumar.
Hi, hi.
Hello, Dr. Vijay.
Yeah, hi.
Hi.
It's Onam time here, you know. Onam is tomorrow.
Yes, I didn't
yeah.
realize that. So it must be full of festivity, or are people lying low?
Rona, it's not that much. All festivities are subdued now.
Yeah, well, it's desirable. I mean, you know, now it's Onam, Ganapati, Muharram. Again, you know, this whole mash of all festivals. It's very hard for people also. They are beginning to give up.
Yeah.
We had 1,800 new cases in Delhi yesterday and day before.
Yeah.
We had a patient who came to our labor room diagnosed positive, and then she was in the trauma center. She went away, left against medical advice from the trauma center, which is our COVID hospital, and then came back to the labor room another time, didn't disclose that she was positive.
My goodness.
Yes, then somebody found it in the reports, and husband said, so what? So what if I didn't tell?
Strange people.
So I keep emphasizing that just assume that the patient is positive. Yeah, I mean, like, don't presume that she's negative, presume she's positive. How about you, Dr. Shankar? How are you doing?
Yeah, keeping busy, confined to Coimbatore, but keeping myself busy. But it's
It must
very
be a
strange
record.
times. Yeah, I've been traveled after March 20th. Fortunately, I didn't undertake my last the foreign trip in March. Otherwise, I would have been held up there for ages.
Oh, yes.
So, yeah.
Oh, yes. So true. I think it's a wonderful thing that Sabhyata and Lata had started this series of lectures.
Yeah.
And it was very well appreciated. Even the last round, the research methodology, they found speakers who could make it so interesting.
Yeah.
It was very well received.
Actually, yeah.
Yeah,
We really appreciate your coming for this program today.
yeah, this is like a touring circus, Dr. Nirja. You would have heard several times. And I feel, 3 years down retirement, I feel so outdated nowadays.
No, but not much has changed, and it is just
Yeah.
another marker of the bad luck that dog cervical cancer. That just as we are getting the limelight, COVID comes to steal the show.
Yeah, exactly.
Just
Everybody is
when-
talking about COVID, and actually, this has put forth everything backwards for several years. Leave
Yes,
alone service cancer screening, everything. The way the emergency services, the routine care, and everything has been affected throughout the whole.
it's
I
terrible.
think
How
this is a
many?
major response for a common viral infection. There will be so many things coming in future. Are they going to lock down indefinitely countries? I think the post-COVID, we will be seeing quite a lot of mortality due to, ill health and poor nutrition and starvation and many things.
And
It's
especially
so sad.
now that the deaths are so few comparatively,
Yeah,
now death rate
exactly.
is definitely very low, even though the infection rate numbers are up.
Yeah. Actually, for every diagnosed case, there will be at least 3 or 4 undiagnosed cases. So if you really look into mortality, even in the places where they document among diagnosed cases like 10%, it will not be more than 2 or 3%. And in India, it is much lower, and it is like a flu, like which will kill old people, because unlike in the West, we are not used to that type of influenza, which kills a lot of old people. So this is the first time we are experiencing this type of viral illness. But it is, but the way the economy has been sapped, it's terrible.
And we've been seeing these endometrial cancers. We are opening, so many of them have had deposits in the pelvic peritoneum, bladder, and all, which is something you never saw with CA
Yeah.
endometrium, but they're just not presented. And it's not picked up in imaging. And even if it were, it's the endometrium anyway, but it's really sad to see that. The
Yeah.
only one which was good news was that the tuberculosis has possibly benefited.
Yeah.
That because of the masks and the early reporting of coughs, they are getting that.
Yeah. And another thing is, of course, the hand hygiene and things like that has improved. That is one
Yes.
byproduct of this particular one. I think I should be using the slide share screen option, isn't it?
Yes,
And Dr.
yes,
Nirja.
yes,
Yeah.
yes. She would have done that with you in the rehearsal, no?
Yeah, we just spoke. We haven't
Okay,
gone
okay.
through the things.
Okay.
But sometimes, fortunately, the internet is holding today. Sometimes the bandwidths are so low.
True.
For one of the presentations, I had real difficulty. It went bizarre. So I am sometimes always skeptical about this Zoom presentations and webinars and things like that. Depends on very much on the bandwidth of internet. Sometimes it is quite bad. Yeah.
Or maybe you can send one copy to somebody else also to just share.
Yeah, I haven't sent this today. It holds on. The bandwidth is quite good,
Okay,
but I have
good.
sent the copy of my presentation to Lata.
So good evening, everyone, and we welcome you to the clinical practice lecture series. This is the first of the lecture series. We had a very successful research methodology course. The chairpersons for this evening session will be Dr. Nirja Batla, who is a professor and the unit head, Department of Obstetrics and Gynecology, AIIMS, New Delhi, and Dr. Sabyata Gupta, who is our president of AOGN. I hand over the session to the chairpersons.
Thank you, Dr. Lata. Thank you for inviting us to be here for this program today and for conceptualizing such a nice program. My co-chairperson, Dr. Sabyata Gupta, the president, and Dr. Lata have done a fabulous job with the first round of research. So my compliments. And indeed, it is a great, great honor for us to have today with us Dr. Sankaranarayanan. And actually, really, I don't think, Dr. Shankar, that you need any introduction to anyone in India, leave alone anywhere else in this world. But I do think that they have a slide prepared for your introduction. And it will be nice if somebody can share the slide of the introduction now. Dr. Shankar was previously the head of the Screening and Early Detection Group at the International Agency for Research on Cancer in Lyon, which is a WHO body. And we have had the good fortune of collaborating with him for a couple of decades now. And I think I value him as one of the best teachers I had and whom I learned so much from, really. And if I can pass a fraction of that on to my students, I will consider it an effort well done. And now he is presently working with the RTI group and still very actively engaged in advising various governments and various policy makers about how to carry forward the cervical cancer elimination to its logical conclusion. He has a number of very, very impactful publications, more than 280 in international peer-reviewed journals, including NEJM, Lancet, Lancet Oncology, and so on. Has visited and provided technical support to more than 100 countries on this subject, and has been the recipient of several awards for work in international oncology and cancer control, notably the Ernst Wertheim Award at Austria, and the Princess Salma International Prize in Morocco, the Paul P. Carbon Award for International Oncology in USA, the British Colposcopy Society Founders Medal, etc., and so on. And I must share with you that in Eogen, when in the Eogen regional, when we were planning at the start about instituting some prize for the prize winners at the conferences, actually it was very, very strongly recommended that the award for the best paper should be named after Dr. Shankar. And he declined because he was working in WHO at that time. But I think we have to revisit and to see now that he has retired, we can still have the prize in his name, because honestly, he has inspired and helped generations. I know I stand between you and him, but I cannot at all, sort of pass this opportunity to share with the audience the way Dr. Shankar groomed us and helped us. And he would even forego the business class travel he was entitled to and travel economy, and use that money he saved to fund us to travel to conferences. And by us, I mean so many of the sites that were working and to make us grow. So, I mean, on every plane, personal, professional, we learned so much, Dr. Shankar. There is no way to repay the debt except to pass it on to our students. So with that, I invite you to give your talk today, and I'm sure everybody will gain meaningfully.
Thank you very much, Dr. Neerja, for the kind introduction. I don't have words to thank you for all the kind words and kindness you have shown to me over the years. And I always say you have been my anchor in New Delhi and looked after all our interests with such diligence, and I'm eternally grateful to you. I would like to thank you and Dr. Gupta for chairing this session, and then of course, my grateful thanks to both Dr. Leta and Dr. Ritu for giving him an opportunity to interact. I would like to say that I'm not going to say anything that we do not know. The only thing is I'm trying to, summarize some of the recent happenings in the context of cervical cancer elimination. I think this is a big paradigm change, because in cancer, we have been always talking about control rather than elimination, because intuitively we think cancers cannot be eliminated. But fortunately, some of the cancers which have a major infectious etiology have a possibility for elimination and cervix cancer is in the forefront. And we always used to say this is the most preventable cancer, but yet not prevented, particularly in low and middle income countries. Quite often we use these words eradication and elimination interchangeably, but they are very distinct. In eradication, it is zero incidence of disease, but we can stop all the interventions. The typical example is smallpox. There is no smallpox cases, but there is no need to vaccinate them anymore for smallpox. So that is eradication. But elimination is theoretically, it is zero incidence of disease, but the interventions have to continue, keep the disease very low. But from a pragmatic perspective, elimination of diseases, we would like to reduce the incidence of a specific disease to a very low level so that it is no longer a public health threat. What is this low level is disputable, and generally WHO fixes the benchmark for what is low. And in the case of cervix cancer, they have defined elimination. If one can bring down the incidence of cervical cancer below 4 per 100,000, this is practically elimination, and it will cease to be a public health problem. But if you intuitively think you can bring down the incidence of cervical cancer to that low level, you can further reduce it, and technically one can achieve a zero incidence. Maybe it might take several decades to achieve that, but that is possible. And I would like to remind that because the biggest opportunity for cervical cancer prevention comes from the knowledge that cervical cancer is caused by persistent infection with the most common viral infection of the reproductive tract, namely human papillomaviral infection. If you see the incidence rates of cervical cancer, how it varies in the world. For example, if you take Guinea in West Africa, the incidence rates are like 90 or 100 per 100,000, very high incidence rates. And if you see the 14 HPV types which cause cervical cancer, their prevalence is like 33% in adult women. In women between the ages of 15 to 60, the frequency of high-risk HPV infection which can cause cervical cancer is very high. And similarly, all these countries, Mongolia, Vanuatu, Nigeria, and all those have very high incidence of cervix cancer, and then they have a very high frequency of human papillomaviral infection. But if you come down at the end of this bar chart, you see Pakistan and Vietnam. In Vietnam, actually, it has eliminated cervical cancer, by WHO definition. In Vietnam, in Hanoi, the incidence rates are so low, they are less than 4 per 100,000. And look at the prevalence of human papillomaviral infection. It is negligibly low. It is less than 2%. Pakistan as well, it is less than 2%. The incidence rates are so low. This comes from Sindh province in Pakistan. And then in between, you see so many other countries with intermediate rates and things like that. India comes on the top 10 countries with the highest incidence. And my colleague in the agency, Dr. Nubia Manos, did most of the studies, and she did several case control studies and follow-up studies, and causality was very much established, and Harold von Surazen identified this virus and he got the Nobel Prize. This is all history. But this particular knowledge has led to two important armamentarium to fight cervical cancer. That is the possibility of vaccination so that one can prevent a persistent infection. Because everyone gets infected, it is an ubiquitous infection, but in most people, in more than 90% of the women, it will disappear within 3 years. And how it disappears, whether it goes into latency or it really goes away by immunity, I mean, that is disputable, but on the other hand, you don't see the infection persisting, fortunately, in most of the women. In few women, it persists, and these are the women who develop cervical precancerous lesions over several years. And then over a period of around 10 years, the highest grade of the cervical precancerous lesion, namely CAN3 and adenocarcinoma in situ, they progress to invasive cancer. This is all well known. So the natural history of cervix cancer is very well known, and this has helped us in improving the prevention of cervical cancer to a large extent by vaccination and by identifying the risk group for cervical cancer, which is people infected with human papillomavirus. Generally, from a pragmatic perspective, any woman above the age of 30 years, if there is a human HPV infection by any one of these 14 high-risk types, we would consider this as a persistent infection. All transient infections technically disappear before the age of 30 years. This is a very pragmatic definition. And this is the benchmark that WHO uses in recommending the age groups for which testing can be done. And the most pragmatic level and the most cost-effective manner, that is between 30 and 39. This is the reason they recommend this age group. That is the age group where there is persistent infection, and this is the age group where you have the highest frequency of the high-grade cervical precancerous lesions, so you can detect them and treat, so that invasive cancer can be prevented. And it is an infection predominantly spread through the vaginal route. And that is one of the reasons we have to vaccinate girls much earlier than sexual debut. And that is one of the reasons the WHO defines the primary target age group for cervical cancer vaccination, HPV vaccination, as 9 to 14. So, in a landmark sort of announcement, the WHO Director General called for cervical cancer elimination for all the member states. And they set the goal and the 2030 targets, like as it is shown here. The vision is a world without cervical cancer, and the goal is to bring down the incidence to less than 4 cases. So how do we achieve this? So this is the route map for elimination for cervical cancer. Vaccinate 90% or more of the girls with human papillomaviral infection vaccine by 15 years of age. And get the target women for cervical cancer screening, and screen 70% or more of them between the ages 35 and 45 years. And more than 90% of the people with a positive result are managed appropriately. And then treat invasive cancers. More than 90% of the invasive cancers are treated so that you reduce mortality by 30%. So we call it as a 90-70-90 policy for elimination of cervical cancer. If all countries can achieve these targets by 2030, I think in few decades, we can bring down the incidence of cervix cancer for less than 4 per 100,000. And fortunately, there are some countries which have already in a very advanced level of implementation, like Australia and Finland, may achieve elimination by 2028 by bringing the rates so low. And in India, in some of the states, if they take very earnestly this message, I think they can reduce. For example, Kerala can easily eliminate cervical cancer provided the government concentrates on vaccination, screening, these 2 areas, because diagnosis and treatment of cancer is much more better in the Kerala health services. I'm just making this point. And similarly, in our region, Bhutan and Thailand have a real possibility to eliminate cervical cancer much more earlier than many other countries in the Southeast Asian region. But unfortunately, there are several challenges. And the biggest challenge, because everybody is talking about COVID, that is why purposely I didn't put COVID here. It is very depressing, talk about COVID, how it has affected everything that we are used to. And this has dramatically affected cervical cancer vaccination. It has affected cervical cancer screening throughout the world. And this is a major challenge. I think this pandemic has to subside for these important activities to recommence. And it is gratifying to note that several countries, they have now come out with clear guidelines, while resorting to vaccination and screening, taking into account the risk for the COVID, the coronaviral infection, and the disease caused by it, the COVID. So that is a major challenge. But there are other major challenges. You can go on listing them. But these challenges should not deter people from introducing, because there are very important examples from the region and from even some of the very challenging continents like Africa, how people have moved forward irrespective of all these challenges, lack of healthcare infrastructure, vaccine misinformation, anti-vaccine campaigns, low in political agenda, very poorly developed health services, and all those things. And these are going to affect every disease, you name it. So it's not very peculiar to HPV vaccination. But on the other hand, the misinformation which has led to vaccine hesitancy is a major challenge. Unfortunately, over the last few years, we are getting over it. The misinformation campaigns are losing steam. And initially, the vaccine was recommended in 3 doses over a 6-month period. We have initially 2 vaccines were available, the bivalent vaccine targeting HPV 16 and 18, the quadrivalent vaccine in addition 6 and 11, and now later a monovalent vaccine targeting 9 HPV types. They are on the market now. And HPV 16 and 18, because globally about 70% of cervical cancers are caused by HPV 16 or 18. Cervix is a monoclonal disease, so it is caused by one virus. Even if there are multiple viruses present in a specimen, it is usually one viral type which causes the carcinogenesis and cervix cancer. So, and initially the dosage regime which was recommended by WHO was 3 doses over a 6-month period. Then later there were several studies which looked into 2 doses and 3 doses, and they showed equal immunogenicity. This is one of the Indian studies which looked into less than 3 doses. Actually, this study was sort of aimed as a study to a randomized trial comparing 2 and 3 doses. And unfortunately or fortunately, due to the events in 2010 when all the HPV vaccinations were suspended in clinical trials, we had to suspend. So this resulted in approximately 5,000 girls receiving 3 doses, 5,000 girls receiving 2 doses according to protocol day 1 and day 180, and about 5,000 girls receiving a single dose. And we decided to follow them. And in fact, I would like to thank Dr. Neerja Butler, because she has been a major supporter at a political level, to safeguard, and as an academic level as well, this particular study, which has faced so many challenges. Thanks to our excellent investigators all over India, we were able to save this study, and it brought out very important results, namely the equivalency of 2 doses and 3 doses for the quadrivalent vaccine. This was one of the evidence base which WHO used for supporting a 2-dose regime for girls between 9 to 14 years. And then, at the moment, single dose is being investigated in randomized trials and things like that. The hypotheses were generated from here. And in the recent WHO SAGE meeting, they even went to the extent of saying, because now one of the major problem is vaccine unavailability. There are not enough vaccines in the market. So many of the countries which were supposed to begin vaccination in 2019, 18, they were not able to begin. So they have postponed to 2020, 2021, 23, like that. For example, Maldives started only this year. They were initially supposed to start in 2017. Myanmar, they were planning to start in 2020. Now they will start only in 2023 because vaccine unavailability. So WHO has now come out with a very pragmatic policy saying that the countries which want to introduce can go with a first dose, and the second dose can be delivered after 3 or 5 years. By that time, we would have accumulated quite a lot of evidence for the single dose, whether it works or not. If it works, there will be a policy change, then people get away with a single dose. But if a single dose doesn't perform in the long run, then of course you can vaccinate them after 3 or 5 years. The second dose being given much later is a much better logistics than much better strategy than giving the second dose at 6 months or 12 months, because the immunogenicity of the second dose acts as a booster, and it enormously supports the long-acting plasma cells to reactivate and produce antibodies. So this Indian study has now shown with a single dose, exactly the frequency of persistent infection is similar to 3 doses and 2 doses. And now we have started screening people. We have very limited data, but even the limited data shows the frequency of CAN3 among those people who received 2 doses, 3 doses, and 1 dose is 0. It is equivalent. So the 1 dose is proving equivalent. And there are randomized trials ongoing in Africa and in Costa Rica. So the results will be out soon. So eventually we may have a sort of policy regarding a single dose. And I am a very strong supporter of a single dose of vaccination. And now, there are so many critics of vaccination. There are people in this country who will think, by screening, diagnosing CAN3 and managing them will prevent cervical cancer, but they wouldn't believe by giving vaccination, if you prevent a CAN3, you cannot prevent cancer. So this is very strange. And actually, some of these early introduction countries in Nordic region, UK, Canada, Australia, New Zealand, in many places, they have already started showing the vaccine efficacy. The vaccine efficacy in terms of reduction in CAN3 disease. This data is from Finland, which is one of the excellent vaccine registries and cancer registry. And they have clearly shown in vaccinated cohorts, of course, the numbers are small. There is no cervical cancer cases. The follow-up is continuing. And in fact, at every level, we have shown this reduced frequency of vaccine targeted HPV types, reduced frequency of genital warts. Herd effects are already evident, and reduced cytological abnormalities. The referral rates for colposcopy have come down, and there is reduced frequency CAN2 to 3. And even in reduction in cancer in vaccinated cohorts are being observed. So the evidence base is quite strong. And this is again from Finland, from 2 studies. The people who are always pitching on the safety of vaccine, HPV vaccine is very safe. I do not want to go into more polemics here. In fact, this is one of the safety is very well documented with this vaccine. There are more than 300-400 million doses which have been administered, and not even a single death can be linked to this vaccine. But there are so many misinformation campaigns which affected vaccination coverage in Israel, in Japan, in Colombia, and places like that. And except Japan, in other places are coming up. The coverage is improving. I just wanted to show an example from the region, how Bhutan went around. Bhutan had a pilot study in 2010. And at that time in India, we suspended cervical cancer vaccination. And then Bhutan hesitated for a month and then made a quick decision. They completed the pilot study. Based on the pilot study, they went for, in 2010, they went for vaccinating 12 to 18-year-old girls, 47,000 girls, with more than 90% coverage for the 2 doses through a school-based program across Bhutan. And then for some strange reason, they changed over from a school-based intervention to a clinic-based intervention, and the coverage went down to some 60-70%. And then again in 2014, they switched over to a school-based intervention with 2 doses. Now their coverage is much higher, more than 90%. And Bhutan, the way they used is, for the first years, it was donor support from ACCF, the Australian Cervical Cancer Foundation. And then once that first 5-year support went off, the government of Bhutan committed buying the vaccines, because Bhutan is now not a Gavi eligible country. And now they are switching over. So Bhutan was several years suffering from a cytology-based screening, which was not effective. They did some cardinal studies in collaboration with IARC, with my colleagues, Sylvia Franceschi and others. And they found cytology is not working. They had their own evidence. They are switching over to HPV-based screening. And in India as well, there are some important developments. Punjab is vaccinating in 2 districts, but Sikkim as a state is vaccinating the entire state. In the first year, they covered 9 to 14-year population. And then from subsequent years, they are targeting the 9 to 9-year-old girls. Around 8,000 girls they are vaccinating every year. It is continuing. And Himachal has made a decision to start vaccination next year. But from a pragmatic perspective, from a vaccine availability point of view, it will take much more time. But the good news around the corner, and which has been also affected by this COVID pandemic, the timeline is affected, is the possibility of an Indian vaccine. There are Chinese vaccines which have shown equivalent efficacy as that of quadrivalent and bivalent, but for some strange reason, they are not yet licensed by the Chinese FDA. But in India, the Serum Institute have a quadrivalent vaccine, which has completed phase 2, phase 3 trials, and phase 1, phase 2 trials, and the phase 3 trial has to ongo now, but this has been temporarily postponed because of the COVID epidemic, because field activities are restricted. If this COVID epidemic was not there, probably this vaccine might have been licensed early next year, but at least it will be in the horizon in 1 or 2 years' time, and that will change the global scenario of introducing HPV vaccination. Whether we like it or not, at the moment there are 130 countries which have introduced HPV vaccination either nationally or as in small regions as a demonstration project. So the vaccine coverage geographical coverage will increase, and the logistics are already there. So the vaccination coverage is increasing, but the problem of this vaccine availability is a huge issue. And this will be controlled only by availability of vaccines from India and China. And let us hope that will happen in the near future. But what will happen in the field level is, these vaccinated cohorts will have very low frequency of non-vaccine targeted HPV types, and there will be very few cytological abnormalities. So cytology and visual inspection with acetic acid will be very challenging in the vaccinated populations. And these are populations which should be screened by HPV testing, because that will pick up the risk group for screening. So this is a very important thing. And again, the entire screening paradigm will change. Screening can be initiated later in life, like 35 or even 40. And a single vaccine, a single frequency of screening may be sufficient, because it has a very high negative predictive value. In fact, now we have followed a population in Barshi with a single HPV negative experience over a 15-year period. The frequency of cervical cancer is extremely low in this population, indicating a very high negative predictive value for cancer. And in Western trials and Western populations, they have shown a very high negative predictive value for CAN3 and adenocarcinoma in situ. So it has a very high negative predictive value. So one can get away with a single vaccination, at least in low and middle income countries. But depending upon the resources, one may repeat it after 10 years or so. So there are so many opportunities. And again, if you see this in many places, people were struggling with introducing visual inspection of acetic acid. It's a clinical test. There is nothing wrong with it, but it has its own limitation, and it is not a test which is possible to apply in postmenopausal women because of the movement of the transformation zone into the canal and the brittleness of the epithelium. But on the other hand, introducing VAA programs will establish an infrastructure, a screening culture, trained human resources, establishment of diagnosis and treatment platforms and things like that. So ultimately, in this platform, an affordable HPV test can be fit in as a primary screening test. And in fact, in one of the very early trials on HPV screening in the world, in India, in Barshi, with Dr. Nine and Dr. Dinsha, late Dr. Dinsha and late Dr. Nine leading the field work with Mrs. Jayant and Dr. Malvi and Dr. Surendra Sastri. It's an IR collaborative study with Tata Memorial Center and Nargis Memorial Cancer Hospital. It's supported by the Gates Foundation. We showed a single round of HPV screening can reduce cervical cancer mortality by 50%. This was a very important finding, and this is a very important support for introducing a single frequency HPV screening. And in fact, if you see here in this randomized trial, there were 30,000 women screened with VIA, 30,000 with pap smear, and 30,000 with HPV testing. And the pap smear negative and VIA negative women had much higher incidence of cervical cancer as compared to the HPV negative women, which is shown in the lowermost curve here. In the first 5 years, there were literally no cervical cancer cases in the HPV negative women. And then gradually there are very few cases. So the incidence rate was like less than 1 per 2,000 HPV negative women. It's a very low rate. And if you look at the mortality in the first 8 to 9 years, there was no mortality from cervical cancer in HPV negative women. So these are very supportive of the high negative predictive value. Even with VIA, one can reduce cervical cancer incidence and mortality, but provided we are comfortable with over treatment. This is a Southern Indian trial where almost 4% of the women were treated with cryotherapy by nurses, because the nurses were very not sure about, let the nurses forgive me, but they over-treated and they did a good job. And that is the reason I think in this trial that VIA screening followed by treatment with cryotherapy and with very few cases treated by LEAP, there was a significant reduction in cervical cancer incidence and mortality. And all these studies have added the value for making policy decisions globally. I'm very glad to say the Indian studies have driven policies in many other countries, much more than in India, I would say. In India, even though we have introduced cervical cancer screening programs, they are mostly paper tigers. Their coverage is very low. No infrastructure has been built in most of the country. There are no providers. So screening is a huge unmet need in this country. And there are so much of WHO recommendations which one can adapt in any national setting, by pragmatically thinking and limiting our objectives and being less ambitious to begin with. And from that perspective, Tamil Nadu state introduced a VIA screening program through the health services. And just like any other screening program, even in Europe, it took around 20-25 years for most of the screening programs to stabilize. They are not very easy undertakings. It requires an organization. There are so many things in a screening program which can go wrong unless you have proper policies and commitment and resources to make the screening program work. Simply, they don't exist in India. But one thing I should say, in the Tamil Nadu program, in spite of this COVID pandemic now, screening is still continuing. And they have switched over from cryotherapy to thermal coagulation. Ultimately, I'm pitching for HPV testing as the primary screening test that countries should choose for in a public health program where there is no functioning, efficient cytology screening program. Even those who have cytology screening programs like Australia and Netherlands have switched over to, Argentina have switched over to HPV testing based program. So in future, the primary screening test of value is HPV testing. And This has so many advantages over cytology. The problem is with its technology, but at the moment there are so many new platforms are being developed. I hope these platforms will become a reality soon, where one can have point of care testing like within an hour, very simple technologies. And again, these simple technologies have been, again, the development of these technologies have been affected by the rush to develop platforms for COVID diagnosis and COVID prevention. So COVID is affecting every aspect of cervical cancer screening. And one of the major problems with HPV testing has been, it's a test of infection. It is not a test of disease. Not all people who are HPV positive are going to harbor disease. So how are we going to triage? At the moment, the most promising pragmatic approach seems to be the tests where one can have HPV testing generic for the 14 types. And then you have in positive women, look for HPV 16 and 18. And if they are positive, direct the interventions immediately. Otherwise, recall them after 1 year. So there are various post-HPV positivity triaging algorithms are evolving. And I believe the algorithm which is based on HPV 16 and 18 triage is the most pragmatic at the moment. And this is the line, almost about 9 to 10 platforms which are being developed for application in developing countries is using at the moment. And then finally, this is the first time, WHO has looked into, the value of treating invasive cancer. And generally, in many places, treatment of invasive cancer is an anathema. That's a very poor clinical judgment, because people with cancer, they suffer. And cervix cancer is one disease which has standard treatment protocols. Early disease, the cure rates are very high. I'm talking about real cure rates. In stage 1 disease, actually more than 90% can be cured. In stage 2A disease, more than 75% can be cured. And even with a 3B, 3A disease, there is more than 40-45% can be cured. I think the value of diagnosing and treating cervical cancer early in those unfortunate women who had never had the opportunity to get screened. And of course, forget about vaccination because there's a recent development. I think the value of treating them with radical surgery or radical radiotherapy is very much recognized in this one. And this will add to fastening the elimination of mortality from cervical cancer. This is not going to reduce incidence, but it will certainly reduce mortality, and it will improve quality of life. But from that perspective, I think there is considerable capacity needs to be developed within health services. Health services cannot be developed for a single disease. Health service development is something which is generic, where there is vertical investment, where there are right policies, and the usual norms of development of the healthcare infrastructure for cancer have to be considered. One of the very useful norms is like for every 2 million people, one need to have an external radiotherapy machine. I mean, I'm just giving an example. And improving, and for cancer, improving surgical capacity is a very, very important intervention, which is seldom recognized. And for solid tumors, surgery is the primary form of treatment. And this truth is should not be forgotten. And then similarly, in advanced, locally advanced disease, concurrent chemoradiation helps in. So all this can result in a certain level of reduction in cervical cancer mortality, which will add to the elimination paradigm. And I just wanted to show you, from a health service perspective, what is the radiation therapy capacity. For example, if you take India, we have 1.3 billion people. The most latest projection is we have 605 external radiotherapy machines and about 316 intracavitary therapy units. We need actually double the number. But if you look into our neighboring countries like Bangladesh, Myanmar, Indonesia, they are in a much poor shape. Actually, in the Southeast Asian region, Thailand has one of the best indicators for any healthcare-related indices. Universal healthcare, excellent accessibility for cancer diagnosis, treatment, and follow-up care. A screening program which is switching over to HPV testing. And beautifully they introduced HPV vaccination, a pilot program in Ayutthaya province. And then in 2017, they introduced in 1/3 of the provinces. In 2018, they introduced another 1/3, so 2/3 were covered. 2019, the entire country was covered with HPV vaccination. They vaccinate around 600,000 girls every year. And the radiotherapy capacity in the region is optimum only with Thailand at the moment. So finally, for the naysayers, Australia will be potentially the first country to eliminate cervical cancer because they are in the right direction. Australia has one of the most efficient and effective national cancer control program, which is carefully monitored. Vertical inputs are done in a timely manner, and there is proper evaluation and monitoring. And they expect by 2028, their incidence rates for cervix cancer will drop to less than 4 per 100,000. So pragmatically, one would say for elimination, a global policy for elimination is vaccinate a single year cohort, which is 11 and 12, or it can be 9, whatever it is, depending upon the local convenience. And at least provide a single HPV screen at 35 to 39 years. But if it is not really possible, at least introduce a VAA screen and switch over to HPV screen later. And if resources permit, you may think of a screening interval like 7 or 10 years with HPV screening, or 5 years with VAA screening. And then make every effort to diagnose cervical cancer in symptomatic women in stage 1 disease and manage either with radical surgery or with radical radiotherapy. But ultimately, all these philosophies will translate only when there is adequate healthcare financing. And in fact, if you look into the health services of India, accessing healthcare has become very difficult. In fact, this is very expensive, out-of-pocket payment. Our government-supported insurance policies are to the low-income groups are not adequate enough. And there is much more to be done to bring in universal healthcare very rapidly into this country. If you look into Thailand, the picture, the country which introduced universal healthcare in a 10-year timeline is very, very impressive. In fact, almost the entire Thai national population seeks services in the public health services, and the private healthcare infrastructure which exists mostly caters to expatriates. But at the moment, if you look into the public health services, it is grossly inadequate in this country. And in fact, the governments are withdrawing. And even with our insurance schemes, the government becomes a payer of health service. They are not a provider of health service. I think unless this equation changes, I think we will have a major problem in accessing good quality healthcare in this country. Healthcare financing is a topic which has to be seriously considered in the political agenda. It will be interesting to see how in future the political parties deal with the topic of healthcare financing and bringing in universal healthcare. And as we said, one of the very important interventions is HPV vaccination for 9 to 14-year-old girls. But to make it more cost effective, we can combine this with other interventions like screening for the vision, other vaccines, the commodity delivery like anti-helminthic treatment, iron and folic acid supplementation, menstrual hygiene education, and all those things, reproductive health education, and all those things. And then finally, I'm coming to the end of my presentation, looking into India. In India, the incidence rates vary between 6 to 30 per 100,000. The crude rates of 6 are seen in Kerala. And still it contributes. I think China has now overtaken India for the global contribution. They contribute more cases and deaths than us for the global total, but still India contributes 18%. And we have everywhere the incidence rates are declining in India. And this has been used as a ploy by people. Oh, incidence rates are declining, just go on screening. Screening is phantom here. Okay, these rates will flatten out after some time. When a disease is declining, this is the best opportunity to eliminate. So if you put interventions, the lesson is the drop in incidence rates will be much more rapid, and one can save quite a lot of resources. This is very clear. And this is the age-specific incidence rates in Chennai. Chennai has one of the best cancer registries anywhere in the developing world. So you look at the age-specific incidence rates during the period 1983 to 2015, over a 30-year period. There is significant decline in cervical cancer incidence rates between the ages 30 and 60 by leap and bounds, which has come basically because of economic development, better nutrition, and there must be some role for the routine hysterectomies people do. Maybe we don't know because we haven't really looked into better hygiene, and all these things may contribute. But giving vaccination will substantially lower rates and will bring down to the elimination threshold very rapidly because of the already declining experience. We are not like in Eastern Europe and Russia, where rates are increasing. If you see the rates coming from Moscow, it will be reverse of it. The rates coming from Bulgaria, it will be reverse of it. But this type of reduction, and a very impressive reduction in age-specific incidence, can be shown in the Indian registries. Of course, one of the very sensible investments that we made was the National Cancer Registry Program of India, which is yielding very important data at the moment to guide our cancer control initiatives. I think this is my last slide, and I've just shared with you some random thoughts, how we can go about eliminating cervical cancer, which is yet not prevented adequately in many countries. Thank you for your kind attention.
Thank you. Thank you very much, Dr. Sankaranarayanan. And I think I'll not waste any time in between because I can see very many questions coming up in the chat box. And I'll request all the other participants to make the most of it since we have the stalwart in the field with us. So just write down your question and queries in the chat box. So we have the first question coming up, which is that why, Dr. Shankar, is the incidence of cervical cancer so low in Vietnam?
Okay. This is due to a peculiar social environment which existed in Vietnam. North Vietnam, this was a communist regime for many years, and then many things were strictly controlled, including there was very little activities which can increase the infection frequency with human papillomaviruses. It is exactly like the situation in Mao Zedong's China. And in fact, if you look into Shanghai few years back had an incidence rate of 5 per 100,000. It declined from 35 per 100,000 in the mid-1960s to around 5 per 100,000 by mid-1990s. And this is because of Mao's regime. And then China opened up, and China became, there were economic development and things like that. And then the rates are climbing up in China. It's not only in Shanghai, in all those places. So this was the changes which happens in social most early debut of sexual onset and all those things, which are strictly controlled in an authoritarian regimes. So it will be very interesting to see what will happen in Vietnam in coming years. And even within Vietnam, there are two registries. Ho Chi Minh is, Hanoi is showing this very low rates of cervical cancer and very low frequency of HPV. Where you go to former Saigon, which is Ho Chi Minh Ville, which has a cervical cancer incidence rate of 30 per 100,000 and about 15% of the women infected with HPV. So you can infer.
When you were making a mention that there is a possibility of, Kerala preventing and eliminating cervical cancer, I saw a question coming up in the chat box that was, what about Sikkim?
Yeah, Sikkim is quite possible. In fact, at the moment, the way Sikkim is moving forward, pragmatically, Sikkim will eliminate cervical cancer much more earlier than other states because they've introduced the HPV vaccination quite early. And their screening program is still based on VIA, but they might switch over to, there are a lot of discussions going on in switching over to HPV-based screening. So Sikkim is an important candidate for elimination.
Thank you. And what's the reason for shortage of vaccines these days?
Okay, vaccines are produced by two companies. Okay, and they supply for a global market. And their installed capacities are only this much. And I don't know what's the reason why they don't increase their manufacturing capacity. But on the other hand, if you look into Serum Institute of India is the world's largest vaccine manufacturer. And in fact, among the pediatric vaccines, almost 60% of the pediatric vaccines globally is from Serum Institute of India. I know when they produce this vaccine, they will have an enormous capacity. And even if you look into the press meets on the COVID vaccine development, they are developing 3 vaccines and their production capacities are quite large. So this is something to do with production capacity, as well as the pricing policy, demand, and all those things, because so much of commerce is involved here.
We can understand. We have yet another question from Dr. Ruchi Pathak. She's asked you that in vaccinated population, can HPV screening give false positive result?
Excuse me, can you repeat?
She's asked that in vaccinated population, can HPV screening give false positive result?
Yeah, in vaccinated population, if you do a HPV test could be positive because of non-vaccine targeted HPV types. Because if you use a bivalent vaccine, it protects HPV 16 and 18 and gives some cross protection in some people. If you use a quadrivalent vaccine, it protects against, again, HPV 16 and 18, monovalent about 7 oncogenic HPV types. So if you do a HPV test, they can be positive mostly because of the non-vaccine targeted types. And some of them can be breakthrough infections, People might have been infected by the time they received vaccination. This is the real risk of vaccinating older women, So I wouldn't call this as a false positivity, but I will say this as the HPV test becoming positive in vaccinated women is mostly due to the non-vaccine types, non-vaccine targeted types.
There's yet another question, which is that what is your view about cryotherapy versus thermal ablation?
Both are equivalent in efficacy, but thermal ablation is much more, I will put my weight behind thermal ablation for these reasons. Simplicity of the equipment, portability, less treatment time, and more patient acceptability, and less post-treatment discharge, and equivalent cure rates. And the consumable, you know, over the long run, I think you save money with thermal ablation. And that is one of the reasons, you know, thermal ablation is becoming more popular. It has been reinvented because initially it was used by Ian Duncan in Scotland. And then Dr. Ilancheran and colleagues used extensively in Singapore. Actually, what happened was we were finding very difficult to sustain our cryotherapy services in Africa. And that is how we went into thermal ablation in Africa, and we were really impressed. And then before I left the agency, we had a major grant from NCI to develop a handheld portable thermocoagulator, battery operated. So at the moment, there are two thermal coagulators available, one from the German make and the other is the US make. Both are very good, affordable and portable. And then at least with the US one, I have quite a bit of an experience. With one recharge, one can treat around 30 to 35 patients. And with at the moment, initially we recommended 45 seconds, but at the moment we have reduced to 30 seconds. So I'll put the weight on thermal ablation.
So Dr. Shankar, would you say that there's any advantage to getting the regular machine and cannot just, or is it okay to just go for the battery operated because it may be a cheaper option?
Yeah, it may be, it's a cheaper option. I mean, even the regular machine is portable, you know, Dr. Nirja, it's portable.
Yes,
but
yes.
This one has an inbuilt light source and it is easy to handle. You can just put it in your bag and then take it with you. So there are a lot of advantages like that. Actually, in Africa now, Zambia extensively relies on thermal coagulation because, you know, initially I gave 1 unit free and they were so impressed and they bought 25 units. Now they have equipped all their programs. Similarly, Tamil Nadu is switching over to thermal coagulation now. They are phasing out cryotherapy.
With 2 probes or just the one then?
You know, the machine now comes with 2 probes. So I recommend flat probes, not with the endocervical nipple. So the machine comes with 2 batteries, rechargeable batteries, and with 2 probes. And unless you drop the probe, it doesn't break. I think it is the equipment is about 3-year experience it is very sturdy, both the German unit as well as the US unit. So the price should be the deciding factor. Whoever gives you at a better price, you go for it.
So,
there is a Chinese thermocoagulator. I was not aware, but I don't think there is a Chinese thermocoagulator yet. If you have that information, please please give us the details. Okay, why not the nippled one? The nippled one will stimulate the endocervix. Endocervix is rich in autonomic nerve fibers. So this is something which can lead to severe pain, cramps, and even fainting attacks. And if there is an endocervical extension, just putting a nipple and then ablating it is not the solution. One should go for excisional method. So that's a reason that we support flat probes.
So we have yet another question for you, sir. What is the harm of over-treating? At most, you freeze the cervix, and that's for cryo. But of course, malignancy should not be missed. There are good Indian guidelines for deciding who needs cryotherapy.
Yeah, I think, I mean, you said it, madam. The malignancy should not be missed. But otherwise, if you directly look into what is the consequence of over-treatment, to me, maybe you may consider me as a little boorish. I say no. There is nothing to worry about an over-treatment. Because people used to say pelvic inflammatory disease, but pelvic inflammatory disease is many things for many people because this is one disease with a very wide definition across the world. And you know, a real functional stenosis I've never seen. So I'm using this old physician's anecdote, but I would maintain it is more safe than crossing the road in India.
So we have yet another question. That is, it is argued that via screening has helped in downstaging the disease and decreasing the mortality rather than the incidence of the disease. What is your opinion on this?
Yeah, okay. That depends upon the validity of the VAA you provide. If you see the 2 Indian trials, the Bombay trial, the mortality reduced mainly because of downstaging. Because at the time they started the studies, VA was just evolving, and we did not have so much of knowledge about how to train the providers, and what are the pitfalls and things like that. So if you carefully provide VIA and especially in premenopausal women, studies both in Africa and India, both cross-sectional and randomized trials in South Africa and India, have shown you can really detect significant proportion of CAN2-3 disease, and by effectively treating them, one can reduce incidence. But provider training, monitoring, and quality assurance is very important. You know, VA is not a very easy test, because people will think, oh, it is very simple. It is not. It requires quite a bit of an understanding of the pathophysiology and the provider interest and the provider learning curve and the provider self-auditing with the histological outcomes of their diagnosis.
There's a question regarding your expert opinion about GeneXpert and TrueNat for HPV testing.
Yeah, you know, these are useful platforms, you know, but on the other hand, you know, the GeneXpert, the equipment cost is quite high. So we need to share, but nobody shares anything in anywhere. You know, the machines may be lying down idle. So it is being treated as a point of care test, but it will not depend upon machine availability and how people share it, because you cannot buy a GeneXpert machine and keep it everywhere, because the machine is basically expensive. And especially when you increase the number of samples being tested at one go, the price rise is exponential. The TrueNat is a good platform, but their HPV cartridge has only few oncogenic types. So provided, I think there is a development going with, because I understand TrueNat is now collaborating with the British company, you know, where TrueNat will manufacture the equipment, so it is affordable, and the British company will make the cartridge, which will have the 14 HPV types. So these types of platforms are being developed elsewhere as well. I think they will, once affordability improves, the technology becomes simple, they will be interesting.
Because I think, Dr. Shankar, this in Kenya, they started the model of doing GeneXpert with the thermal ablation kind of a study supported by the WHO, isn't it? And
yes.
You're right that they're everywhere for TB, but will they be available to our cervical cancer? Where is the load going to lie?
Yeah.
But TrueNat has adapted very rapidly for COVID.
Yeah, yeah. Because now everybody wants to make money with COVID, you know. So COVID has affected every aspect of cervix cancer screening, cervix cancer control, cancer treatment, everything. Name any disease, every disease is now affected. They are all put in back burners.
So maybe they can pivot quickly to do the cervical cancer as well now.
Yeah, yeah.
We have a question from Dr. Shalini Rajaram. She's asked you that a new projected incidence rate of cervical cancer in India is around 77,000. Unlike the Globocan data, which is around 96,000. Why this discrepancy?
Okay, these are due to the methods they use in estimation. The Globocan uses, you know, they do globally, and they use a different weightage for urban and rural rates. The Globocan puts quite a lot of weightage for the rural rates, and the rural rates are higher. And that is one of the reasons the estimate is high. The Indian estimate is mostly based on the urban rates. I think I should check with them what is the weightage they give for the rural cases. But one thing is evident, even if you look into the total number of cases, actual cases occurring in cancer registries, in spite of population growth, they are coming down. So it creates, I agree, it creates a confusion among people in what figure one should use. From a national perspective, nationalistic perspective, one might use the national rates. From an international perspective, one might use the Globocan rates. But me being an IARC former staff member and current visiting scientist there, I will put a lot of onus on the Globocan estimate because they are very carefully done. Very, very carefully done.
All right, so 96,000 you said.
Yeah.
There's,
There was a question from someone saying that the role of biomarkers in CAN. We hear so much about biomarkers for everything which is possible, but ultimately from a clinical perspective, there are very few biomarkers which have become clinically relevant. So at the moment, still I would go more by morphology and from a pragmatic perspective. Maybe I'm a little conservative here. A proper morphology. Somebody commits it to CAN3, CAN2. I wouldn't take. I wouldn't rely on treatment decisions based on biomarkers. But ultimately, if somebody comes out with a biomarker with a very high validity for a definite diagnosis, and then can really discriminate between progressive and non-progressive lesions, that is well and good. But at the moment, I don't think there is anything like that at the moment.
there are a lot many questions coming up. I don't know, Dr. Lata, for how long can we go on?
Perhaps another couple of questions. There was one question which I thought was interesting about the role of HPV testing in pregnant women.
That's good. In fact, all the questions are very good.
Yeah. Pregnant women are very special category. And in pregnancy is the most important thing. I think I'll put the onus on continuing the pregnancy unless there is a very strong suspicion of a malignancy or something. So
I think what they are alluding is the opportunity to catch the pregnant women during, because at that time they are meeting the provider. So what about?
But you try to do anything with the cervix and then scrub and something goes wrong, they will attribute, So this is a very, very risky thing at the moment. And then again, if you look into the risk categories in this country, most of the pregnant women are less than 30 years. So, there is no point in picking all your transient infections. And so I wouldn't put pregnant women as a major sort of logistics to improve coverage.
I think there was one interesting question also about the portable colposcopes, and what is your comment about using them on a mass scale as a screening modality?
I haven't used much of them, but when I talk to people who have used like Deepan with Dr. Mandal and Dr. Nirja, you have done quite a number of studies. I think it appears promising, isn't it?
But the question I think is that should we use it for screening? Because now recently it's kind of getting pushed a little bit.
No. Yeah, colposcopy is a triaging technique, and you see too much in a colposcopic session. It should not be used as a screening tool. It should be used as whether it is portable colposcope or mobile colposcope or a static colposcope, whatever it is, colposcope is a triaging technique to triage women who are positive on an X screening test. This is for sure. Dr. Nirija, you know very well because they were using the screening colposcopy in Austria, which died now. And they were doing this in Latin America, which is almost died now because people see too much and then they overdiagnose and they do too much harm. So one should not use this.
There was one question also from Dr. Bharti about how there's no hybrid capture in her area, but genotyping is there. So can she do genotyping instead?
Genotyping using PCR?
Possibly, yes.
No.
Dr.
In
Bharti
fact, we
was
have to be, for HPV testing as a screening test, one has to use the clinically validated tests because the clinically validated tests have a certain threshold of viral copies on which, above which it is positive. If you use a PCR, it is highly sensitive, used for scientific purposes. They will detect even viral copies like 5, 3, and it is subject to contamination depending upon the laboratory conditions. I wouldn't say one should, I will strongly recommend against using PCR-based HPV testing and genotyping for screening. No.
Dr. Sabita, you have more questions, I think.
Yes, there's yet another question, which is that will there be an increase in non-HPV related cancer cervix if vaccination coverage increases?
In the beginning, when vaccine was introduced, there was a concern. But now looking at the large vaccinated cohorts and things like that, there is no concern that non-vaccine types will take over and there will be a spurt of non-vaccine targeted HPV types causing cancer. Even in our Indian study, we have now, Dr. Nirija, I think we are now in the 10th, 11th year of follow-up, isn't it?
Yes.
We don't see the non-HPV types taking over. So it's most likely it is unlikely.
I think there are quite a few more questions, but I think we may have to bring the session to a close. We will send you the questions, sir. If you're happy to just make a note and send our replies, we will upload the answers onto our website.
You can send it to me by email.
Definitely, yes. Definitely.
Yeah.
So thank you very much. Thank you very much for a very, very informative session. And thank you, chairpersons as well, and all our participants. We are increasing the reach of AOGEN. So it's not only cervical cancer prevention, but we are looking at other areas as well. So with this in view, our next topic for next Saturday will be on hereditary breast and ovarian cancers. We will have Dr. Rajiv Sareen from Tata Memorial Center, who will be talking to us on the Indian data on hereditary breast and ovarian cancers. And the second related talk will be My Mother is BRCA Positive. What do I do now? And this will be by Professor Ranjit Manchanda, and he's from Bath NHS UK. So we welcome all of you back next Saturday at 5. Thank you all very much and have a great day.
Thank you very much, Dr. Leda, Dr. Ritu, Dr. Nirja, and Dr. Gupta, and all colleagues. Thank you very much. I really enjoyed the session because normally I'm very nervous with Zoom sessions because the internet halfway goes through. Then it is a real challenge for the speaker as well as the organizers. So fortunately, it held on. So initially, I was telling Dr. Leda, I will come over to your institute to ensure the continuity, but the internet has been holding on for the last few days. So thank you very much. It was really interesting and nice to see all of you.
Thank you, sir.
In the digital age, it helps.
Thank you. Thank you very much.
Thank you all.
Thank you. Bye.
Thank you. Bye-bye.